But surprisingly, it will come towards the data that's been quoted by article and also been published by the WHO, that suicide rate was increased from 2000, and from 2000 onward it increased till I think 2014 and 15, and then it gradually came down. And the last quoted data was of 2019, which was 6%. It was for 2% of female and 8.9% of male. Now, the suicide rate differs by age, gender, and race. The highest rate in the elderly, the completed suicide. We are talking about the suicide, right? Not the suicide acts. The firearm was the most common method used at 50 to 60% of the cases. 14.25% of suicides occur in a non-behavioral unit of general hospital. That's what I'm saying that. For example, the inpatient suicide, when we compare between the psychiatric inpatient unit, that we saying that a separate psychiatric unit or a psychiatric inpatient in a general hospital, 14% account for the deaths that are happened in the non-psychiatric inpatient units. So it's a huge number. So the hanging was most common, second most common method used by the men. Drug overdose was the second most common for women. For every completed suicide, there are 18 to 25 unsuccessful attempts in general. So all of this data, all of this, what does it mean? Just look at all of these circles. So this big circle is representing the US population. And we come down towards the other circles. The second one is 3.9% of suicidal ideation. But this is only ideation. They have not acted on their ideation. So these are 3.9. Out of these 3.9, 0.6% of the people will actually attempt something, right? And out of these people, and of total US population, 0.01% will die by suicide per year. So, psychiatric disorder are contributing towards majority of the risk factors and the patients. So if we divide them by percentage, so this is the lifetime risk in percentage. So the most important factor is the prior suicide attempt, that accounts for 27.5%. Then you have bipolar affective disorder, that includes the mania and depression. So that's why you can see it is above the major depressive episode. The major depression is 14.6. Mixed drug abuse is 14.7. Saying that a combination of drug abuse plus depression and prior suicide attempt, that account for majority of the cases. So dysthymia 8.6, OCD 8.2, panic 7.2, schizophrenia 6.0. Out of the 6.0 in schizophrenia, 2/3 of the patients were depressed when they committed suicide. The personality disorders 5.1, alcohol abuse 4.2, then general population it is 0.7 to just to compare from the other disorders. Now, this is just article. I thought initially to present a journal club, but I make it a topic presentation about the suicide in general hospital. But I did include this study to the presentation. I'll just take 2 slides for that. So this is a cross-sectional study, a prospective study of 10 years from 1997 to 2000. It was published in BMC Psychiatry in 2011. So the aim was to determine the socio-demographic and psychopathological variables associated with suicide attempt in a population admitted to a general hospital. So what they did is they collected their data from the emergency department for all of the patients that were seen by the Legion Psychiatry. So every patient that was seen by Legion Psychiatry, they collected the data. Then they separated the 2 parts. The first one that were admitted because of the suicide attempt, and the others they accounted as control. So from there, from this control group, they matched the age group, the gender and other aspects to find out what are the most important common factors responsible for a patient who will present with the suicide attempt. You see the sample size by 5,234 patients. They excluded the patients who were admitted directly to a psychiatric inpatient unit and the repeated admissions. Results you will see first to clarify that 361, that is 6.9% of the total sample group was the people who were actually admitted with the suicide attempt. You see, so how to increase your sample size when you are doing a study. So you will not get that many people who will present with suicidal attempt, but they match it with the other patients who presented with other psychiatric problems, and the sample size is huge. That is significant for that study. The variables that were, they found out the important variable associated with the suicidal attempts. So you see that the risk of suicide attempt decreases with age, but completed suicide is more in, we know from the studies that completed suicide actually is high in elderly. Psychiatric illness is a strong predictor of suicide attempt. Certain group psychiatric diagnoses such as schizophrenia, other psychotic disorders, affective disorders, and personality disorders account for these psychiatric groups. The strong single factor predictive of suicide attempt is a prior history of attempted suicide. Now, coming towards the suicide again, suicide itself is not a diagnosis. It's not limited to depression, as you can see from our previous slide. Schizophrenia will account for 6.0%, bipolar, substance abuse, impulse control, and cluster B personality disorder. And not limited actually to psychiatric disorder, as we can see that certain patients, they will present at the time of when they have a state of despair or desperation, they would commit suicide. They are impulsive, aggressive, or disinhibited for any reason, maybe injury, maybe loss, or maybe anything that resulted in the suicide attempt. But this is the textbook. One of my mentor, he was his PhD was in suicide, and he was chosen one of the members of the international suicide group. He once said, I don't see how a person who is not depressed, you will just say that he committed suicide. For example, you are saying that he was impulsive, he was in a state of despair, and he was not depressed. So it is most likely that he is depressed, but we couldn't account for that. So there are some non-modifiable risk factors, and there are certain modifiable risk factors. We will separate them into different slides. Again, I am not presenting all of it. We are going to present each and everything on suicide here today. We will be sitting here for many hours. So I collected few of the points, and just that we can complete our presentation today. So we'll see that gender, male will have more completed suicides than female. They are more at risk. In race, whites versus non-whites, age, old versus young, and past behavior, history of suicide attempt, and past history of family history of completed suicide. In an article from Damam, but they found in their forensic department that the data showed that most of the people that committed suicide were non-Saudis. And from them non-Saudis, the other significant population was Indians that committed suicide. So what are the modifiable risk factors? So it is the treatment, for example, they are going through some procedure, they are taking some medications. There are some other processes like some stresses in the life, some emotional problems with some opposite sex, maybe some job-related issues. There are some points in mental state like current suicidal ideation, depression, anxiety, hopelessness, despair, desperation, intoxication, and there is access to high-density means like firearm inside the house, in their homes, recent loss or a setback. Now, these are the points that denotes that the patient is at high risk of committing suicide. So very clear that most of them are from the checklist from the depression. This hopelessness and desperation, anhedonia, impulsivity, anxiety, psychomotor agitation, emotional lability. And incidentally, this is not the first time I've seen this. Insomnia. Insomnia is also associated with the increased suicide attempt rates. Presence of aggression and violence, decreased self-esteem, poor coping and problem-solving skills, and substance use and intoxication. So what are the low risk? So as we can see, when we do our mental state and the history of the patient is calm and he's not caring about any, he's not agitated, he's not irritable, he's not crying, so he's calm. He's hungry. You came to see the patient and he's eating in front of you. When you talk to him, he is telling you what he wants to do in the future. He will tell you, okay, tomorrow I want to do this. Maybe a month after that I'm expecting that. So he has some plans in the future. Or you can see that from his account that he is making threats. So he's kind of manipulative, that if you don't do this, I will do that. I wanted to say that in the last, but most of us are psychiatrists. I might forget that the psychiatrists are not magicians. You can predict to some degree if the patient is going to commit suicide or he is at a low risk of suicide. But we are not magicians and we cannot predict 100%. For example, we can say, okay, this patient comes to a low risk group, he will go out, he will commit suicide. Or you will say that a patient is high risk, maybe he will not commit the suicide. So these psychiatrists are not the magicians. And I think there are only two types of psychiatrists. The ones, the patients haven't completed a suicide, or a psychiatrist whose patient has already completed a suicide. So just maybe some of us will have this experience, a bad experience in future. I hope we will not face it. So what are the few important points when we do our suicidal risk? So first of all, we should be non-judgmental. The same, either you will say that he's a manipulative person, he did it last time and he came again, there is a small problem, there are so many problems in the world, why he did that, he should have completed suicide. I was working in a surgical ward in a government hospital, and one of my seniors, he says, this is the third time he presented to us and we have to operate on him. Someone go and tell him how to commit suicide. So your personality will come into play when you see the patient repeatedly, the same patient maybe, or you will see that there is a clear personality disorder in the patient. So the first of thing that should be non-judgmental and supportive approach. Evaluate the ideation and the intent. So what are the important points? First of all, presence of suicidal thoughts. What are the details? What is the seriousness of the intent or the attempt? What is the social support, risk-rescue ratio? For example, he wrote something, he informed something, he did it in front of others. Degree of impulsivity. Presence of other risk factors that we discussed previously in our earlier slides. We did the mental state examination and we take some correlative information. Sometimes you will come across the patients who will be self-injurious in very weird ways. We had a patient, a young female, she had personality disorder, but when she presented to the ER, what she did is she took a scissor and she started cutting her skin. It was dermis deep, not epidermis, dermis deep. He cut in front of us and there was no pain on his face. So sometimes you feel that they are bordering to psychosis. Maybe personality disorder, maybe something, but numbness of this pain, she started cutting her skin in front of us. So sometimes you feel that the psychosis is bordering to that, and then when the patient commits suicide. Management, you obviously stabilize the medical condition. Patient presented with suicide attempt, he may have a medical problem, maybe a liver problem, maybe vitally he is not stable, maybe hyperglycemia because he took some insulin, maybe paracetamol, liver problem, and many other drugs. They will come to play, and first of all, they stabilize the medical condition. Then you have to have a safe containment place in the ER. You have to have a separate room for these patients where you do the assessment. Safe by means that if he comes with a suicide attempt that is serious and he wants to do it again, he can do it in the ER. So you have to have a safe room in your ER. You can prescribe a physical or a chemical restraint, supervision with one-to-one patient safety monitor. The person who will do the one-to-one monitor may not be a nurse, maybe a designated person from that who is taught in how to deal with them, just to keep an eye on him. you will remove the dangerous object from in reach. There is repeated observation assessment, and then you will consider initiation of the treatment. But before that, we decide for the disposition. So you will either discharge home, and then there is a safety plan and follow-up appointment. We'll discuss on this safety plan. Admission to a medical unit, either voluntary admission or involuntary admission to inpatient psychiatric unit. Now, there are 6 points that we'll be discussing in the safety plan. So this safety plan is when you want to discharge a patient, and you will ask him to follow up with you in the OPD. So you will discuss with your patient. So you have to empower your own patient, because he needs to feel that I'm in control. The whole purpose of discharging the patient to home is to increase his self-confidence and his, for example, if you will admit, the data shows, for example, if you admit a patient inside a psychiatric unit or a medical setting, so you will take away his freedom and power, he will feel more helpless. So that's why you will see that after discharge, the 72 or 38 hours are the most dangerous hours when the patient can commit suicide again, and it continues up to 2 weeks and months. So admitting a patient will increase the suicide risk if you will discharge him early. So discharging home is one of the ways where you empower your patient. So you will help him, you will not intervene. For example, one of the approaches in the behavior treatment of cognitive behavioral therapy, you will not suggest things to the patient. You will discuss, you will make him say things, right? So that's how you will ask him about the warning signs. For example, he will say, okay, I will not do it again. So your question would be, it can happen again. If it happened before, it can happen again. So for example, if it happened again, for example, what happened last time? What did you felt when you had this ideation? Do you think you are in control? Do you think you are going to do it? What were your thoughts at that time? So he needs to be aware of the warning signs. The second point is then we will discuss his coping strategies. For example, again it happened the same way it happened. What you are going to do, you feel like that you are going to commit suicide, you are not being in control. What are you going to do? How you are going to control yourself? Then other than that, then you will ask him, for example, if you think you are not able to control it by yourself, then what else you can do? For example, there are places you can go, for example, that can distract you from this ideation. There are people who you can go and meet them, and for example, just sitting with the person who is a friend, a good friend, maybe relieve you of this ideation, and you need to discuss with him. And discussing about your mental feeling to a sincere friend is not a bad idea. For example, you can if you trust him, not to everyone. If you can trust a friend, you can discuss it with your problem that you are going through. Maybe he can help you in this regard. Coming towards the second part of that, you have to identify that friend or a family member, right? And if, for example, not sitting with him, you need to discuss with him, and you need to ask him that I need your help. Maybe that is discussing his problem, maybe this is a problem solving approach, or maybe he needs that friend to take him to a psychiatric hospital or any clinic if he wants to. Then the fifth one is, and it implies to us, is what are the mental health professionals or the hospital or the ER. You have a list of that, you have their number, you can go if you are feeling not in control, you can go to a friend, or you can come by yourself to our ER, for example. So open 24 hours, that's what I educate our patients, for example. Our ER is open to you, doctor is there, he is not there to admit you, he is there to help you. If you feel that you are not feeling in control, just come to him, discuss your problem, and he will help you. If there is an admission needed, he will discuss it with you. He will not just admit you because you came to him and you told that I am not feeling all right. Just empowering him again. The last thing is that is to be discussed with the patient and the family. You have to ask him, for example, what are the prior methods that he committed suicide. He had a firearm inside the house. He has the medication inside the house. If he has the access to that, right, for example, and you can discuss with him, for example, you can give this firearm, you're not feeling okay, why not to give it to a family member to lock it for you for the time being. When you are taking police history, you took the, identified the family, you can discuss with them, to search the house for the firearm, and to discuss with them, for example, he is going to home and not to really let him go inside the kitchen if you think that he will harm himself through a sharp object, not to go inside the washroom, or for example he will go in the washroom to remove the things that he can ingest, right? The medication should be locked inside the drawers. So these small steps that might save the patient, because this is the impulsivity. This is in a moment. He will not be feeling suicidal for 5 hours straight. How to kill myself? How to kill myself? The thought will come and thought will go. The thought came. There was an impulsive something. He went there. Door is locked or the drawer is locked. He will have some time to think over it. Maybe a friend will see him in impulsivity. A family member can spot him that he's not feeling okay. So that these small steps will save his life. So we have our modifiable risk factors. We have to treat the psychiatric illness, whatever the diagnosis, accordingly. Mostly the depression. You manage the insomnia and the symptoms, address the availability of the social support, any occupational concerns, provide psychotherapy. There are few things you can do with your patient. There are certain things that needs the psychologist. If you can arrange a meeting with the psychologist, it's better. But there are small things that you do with your patients, not to instill a false hope. You just discuss with them a problem-solving approach. Maybe there is some modifiable risk factor. For example, someone will present, okay, there is a recent breakup. Maybe there is a fight between the family, right? So you discuss with them. Family is there, you are there, you want to help them. Discuss with them, sit together, and something good will happen, inshallah. But don't instill false hope. Communicate with the consultant. For example, if this is a general hospital, the assessment is done by a medical doctor. He can communicate with the psychiatrist. In our case, they will call us, we will go there and we will assess. But before that, for example, if the patient presented to them, I think they need to be aware of what are the few first steps they should do to keep the patient safe. They will not wait for us, for example, 2 hours or 3 hours, and the patient in the ER waiting for the doctor to arrive. In hospital prevention, treating agitation, anxiety, depression, immediately and aggressively. Communicate with the, as I told you before, encourage family support and involvement. Encourage self-communication. Treat pain aggressively if there is a pain. Safety-proof patient rooms. Trained one-to-one sitter or patient safety monitor. There are certain points that we do. For example, when we talk about the safe room, the patient may be in ICU, the patient may be in a general ward, just waiting for the careful observation. Maybe he is in the ER, waiting for a doctor to arrive for the further assessment. What are the important points? So this is actually a checklist. So they have to lock all the cupboards and doors. If they cannot, they should secure it with the zip ties. Bedside card should be there, and for example, the most important point, for example, oxygen, suction devices, otoscope, thermometers, and so on, all should be inside that cart. And remove cards, cables, telephones, monitors, computer tables, whatever he can find to harm himself. Lock them and keep, if they are very important, keep in a cart and keep it outside the patient room. For example, if they need some emergency medication, oxygen, they can take it immediately. Sometimes there are sharp, empty, sharp containers where you throw away the used stuff, should be removed from that particular room. If extra lines are not used, for example, IV lines and other lines should be removed. Check the patient belongings and see for the unsafe items, remove them, document them, and keep them safe. Better for the other belongings to be in the same room, but to be documented. Scan room environment, again you have to look for it. I remember one time I was there. What they used to do in our previous hospital, they used to give the patients, they take him to the smoking room. He had a separate room. They would give them a lighter in front of them. They will smoke. They will take back the lighter. One time they forgot the lighter. He initiated the fire. One time they left him unnoticed inside the room. One of our patients, it was not a suicidal attempt, but he glazed himself with the cigarette on his forearms. So he need to be observed. You will see the cleaning staff. He will bring the cleaning stuff, corrosives and other stuff. Maybe he's cleaning the room and the other stuff is outside, unattended. The housekeeper is not quite aware of the risk the patient can do to themselves. I think in Fahad, I was attending one of the calls. One of the inpatients, he went to the washroom, he broke the tile. From that tile, he cut himself over the chest. You don't know what they are going to do to themselves. Coming towards the psychopharmacology and suicide, it's very clear and obvious that if the patient is depressed and he's suicidal, is psychotic or is suicidal, he needs treatment, and that will decrease the suicide risk. But there is a black box warning we have been talking about of the SSRI used in pediatric population and the patient aged 18 and 24. Initially started with SSRI, and now you see that every treatment that comes for depression, there is a black box warning. They don't want to go away from that. This is a controversial, a conflicting evidence. In several studies, they said there is no evidence, but they are not moving away from that. So it will maybe sometimes, for some people, they will not prescribe, and if they are not moving away from that. So it will maybe sometimes, for some people, they will not prescribe in a fear that it will increase the suicidal ideation. So we need to be careful about that when we are teaching our colleagues. It was, I thought maybe some of us are non-psychiatrists. So, the last important part is not only for the patient. This is for your safety as well. That's what I'm telling you. The psychiatrists are the... I thought initially when I was in surgery and medicine, I don't want to see people die. I choose that field. But some of, or maybe one of your patients will commit suicide and he will die by that suicide. You have to document, and documentation will sometimes save. You will forget something, you will remember by documentation. So if you are in the habit of documenting things, you will do a complete proper checklist, you will do your assessment completely, and you will save yourself as well, and your colleagues as well. One of the patients seen by Dr. Ahmad, he came and saw the patient in one of the general hospitals. And later he was seen, I saw that patient, another doctor, he saw the patient. Patient committed suicide on the 4th day. He jumped from the 3rd floor. There was a committee, they said the psychiatry is responsible. We are calling them and they are not coming and seeing the patient. They checked the notes and they found Dr. Ahmad knows everything was documented there. Our team was seeing the patient more frequently than the ICU and the general medicine. Then the administrator, they decided that psychiatry is not on fault there. And our recommendations were not followed. For example, one-to-one observation, assessment by psychologists, social worker, medications, restraint, nothing was followed. Only their emergency was just to bring the doctor. He saw and document, okay, the thing is complete. Many of time I've seen in maternity hospital or hospital, you come and see and they will not follow. So the best thing is to call the consultant yourself, discuss your plan with them, just so they can follow your plan thoroughly. Otherwise the resident, they will forget. They have many patients. So the document, what are the important things that you need to document is a formulation that includes the risk factors. These are the non-modifiable and the modifiable, or all of it. What are the protective factors? You document the intent, mental status, and what are the observable risk factors. For example, he is anxious, agitation, lability. Then comes towards your clinical reasoning, diagnosis, decision making, your intervention, what you did, what you want to do, what about the follow-up, how frequent follow-up, if there was evidence of firearm inside the house, and what you did then. For example, you discuss with the family or the patient to remove that. But other safekeeping rules that you discuss with the family, for example, keeping the sharp object corrosive away from the patient, all of this. Okay, these are the two scales, it's not very clear here, but these are for the ER people, just as an initial assessment. The two schools is the one, first of all is the ASK screening school for the suicide, and this is for PEDS population. The other one is the Columbia Suicide Severity Rating Scale. Again, these are very, just let me read it out to you.
Sure thing.
Yeah, just to have an idea, but this is for it is for the non-psychiatrist. That's good. So the screen is out. Well, I was on my last slide. The last slide was about documentation. Documentation is very important step, but they say care not documented, care not due.
Yeah.
Whatever you did, you have not documented, it means you have not done. I thank you for all for bearing this long with me. The room is open for any questions if you want to ask.
No. So from my side, nothing صعب الطلاب كاتبين. ما أحضر عليكم بس 5 دقائق بالذات دكاترة MOH. So I am Sam Shahal. I'm professional medical rep. Also key account manager at GSK. مسؤول عن أدوية كبرة لاميكتال سيروكسات كلها باينيم يعني هي البراندز باينيم لكن للأسف الشديد زي ما انتم عارفين أنا حضرت دخلت سوق العمل بعد خروج اللاميكتال الكبرة والسيروكسات من الMOH كان باقي لاميكتال وبعدها بسنة خرجت وزي ما انتم عارفين الأسباب طبعا بسبب الجينيريك وتوفير الفلوس أو سيفنج ماني فور MOH. سو إن شاء الله تعالى ممكن إنه السيروكسات باينين إحنا الآن موجودين في العسكريات وطبعا الخاص كله موجود لكن بإذن الله تعالى ولسه طبعا إن شاء الله الميتنجز الجاية نتكلم عن السيروكسات CR والIR وطبعا في كلام لسه إنه ممكن إنه السنة الجاية ممكن إنه يرجعوا السيروكسات باينين فنتمنى إن شاء الله تعالى ممكن it will be available at MOH. هذا كل اللي عندي أنا إن شاء الله تعالى مستمر معاكم كل شهر إن شاء الله حتى لو نغطي مثلا لاميكتال في البايبولر أو السيروكسات في الإبيسود والحاجات دي حقت الدبريشن والانكزايتي فإن شاء الله تعالى مستمرين مع بعض وشاكر لكم صراحة الله يحفظكم يا رب.
الله يجزاك شكرا. بس عشان الهيستوري مستشفى الصحة النفسية بالمدينة المنورة أول مستشفى على مستوى المملكة اشترت سيروكسات بحوالي فوق من ربع مليون. أول مستشفى على مستوى المملكة اشترت سيروكسات بحوالي فوق من ربع مليون قبل ما يستدعي في الوزارة.
أيوة قالوا لي إن أنت كنت مسؤول عن
ذلك بالجلس.
يس.
فعندنا
الأمر المباشر.
أي
شيء مباشر. Floor for the open for discussion. شباب, any question from me?
I want to ask what is this question about the percentage of suicide in Saudi Arabia? يعني أنا I have يعني a debate about this percentage. And I want to see your opinion about this percentage.
يعني في أمريكا أقل وفي السعودية أكثر. أنتوا إيش رأيك؟
يعني أنا
هو بس في سلايد هنا انا عايز اعرف النسبه دي بتاعت لايف بريفلنس بس لايف يعني انا عايز اعرف كل واحد فينا هنا اشتغل بقى 20 30 سنه شاف كام سويسايد. انا اصلا مش بليفنج في
انا بقالي 14 سنه حالتين 2 فقط.
طيب بقالك كام سنه؟
حالتين.
والله انا تقريبا 9 سنين. ما قلنا من 7 8.
ماشي
ما قلنا 7 8
بس هتلاقي لا في مبالغه.
انا عشان كده
لا في مبالغه جامد في الريت بتاع السويسايد. اظن دي علاقه باكبر ازمه في السايكاتري اللي هي تدخل البوليتكس والانشورنس. حسابات الاقتصاد وحسابات السياسه هي اللي بتدخل في المنطقه. انتوا عارفين ان السويسايد يسقط حقه في الانشورنس. وبالتالي فانا شايف ان القصه زي يعني مثلا من اكثر المشاكل اللي كانت موجوده سوري كيف اللي هي سويسايد المانيا. المانيا could do suicide بس it's not a suicide, it is a mal calculation. هو فاكر انه هيطير فجر من فوق العماره فهم يعملوها سويسايد. هم يبقوا عاملينها سويسايد هي مال كالكوليشن اللي هو ان هو مش هيجروا حاجه. وناس كتير على فكره يجي لها البليف دوت لما تبص من جبل او من مكان عالي انها ممكن تنط ومش هيحصل لها حاجه. السويسايد فيها القصه فيها اكساجريشن يعني. هنا في السعوديه لا اي ثينك الريت قليل جدا.
انا برضه عشان كده يعني 6% يعني نسبة مهولة جدا يعني.
لا قليل الريت هنا، يعني الريت قليل. وبعدين ما ننساش ان في
يعني من كل 100 6 بيعملوا سوسايد.
Suicide is not about 6% is not the people who will die. It's not about completed suicide. 6% is a percent of the people who will commit suicide.
ممكن ideation.
It's complete, no, not ideation. Ideation is very high. It is the attempted suicide, so it means it can be
complete suicide.
not completed suicide.
لما هيبقى attempt suicide in personality disorder specifically, all they are saying they want suicide, they intend suicide. Practically, they did not intend any suicide. Which is the majority in female, الباراسيوسايدال والهيستيريكال رياكشن والكلام ده.
border line personality.
border line. It is a sort of a pressure on a psychiatrist. They blackmail people, they blackmail psychiatrists, they blackmail family. يعني I think ده السبب ان الاتمت عماله يكتبوا في ارقام مع I cannot believe يعني. انا بقالي كده تقريبا 36 سنه سايكاتريست، 36 سايكاتريست. لا
انا اعتقد الهوميسايد يمكن يبقى يعني نسب القتل زادت عشان السبستنس ابيوز يعني.
نسبه ايه؟
الهوميسايد
ممكن
يعني هي دي ممكن دي فعلا يعني فعلا في فرق عن زمان عشان الدراج ابيوز والحاجات دي كلها يعني عامه يعني
احنا بالنسبه لنا في القسم بشكل يومي تقريبا شبه يومي بنشوف